everyone, welcome back to my channel. So today is a new topic, new discussion, and a new 10 marker. So today we're going to deal with fibro-osseous lesions. This comes under bone. Okay, so under the chapter bone, we are going to read a important 10 marker, that is fibro-osseous lesion. So let's see what this has to tell us, and let us begin with the chapter. So I'm selecting a color here just so that I like how it's going, right? So okay, let's get started. So we are starting with the fibro-osseous lesions, and let's see what is there in the fibro-osseous lesion chapter. So for what are fibro-osseous lesions? Fibro-osseous lesions are characterized by replacement of normal bone. So the normal bone is replaced with fibrous bone, right? So normal bone is replaced with fibrous bone. Okay, so not necessarily only fibrous bone, it could be fibrous tissue, that is your cementum or metaplastic bone. Okay, so your normal healthy bone, or I wouldn't say healthy, pathogenic bone is replaced with fibrous tissue. That is nothing but fibrosis lesions, the lesions which replace the bone with fiber are known as fibro-osseous lesions. Now coming to the subsequent formation of mineralized tissue such as cementum or metaplastic bone formation. They have similar radiographic histopathologic features, and diagnosis can only be made on the basis of a full consideration of all the clinical radiographic histopathologic features. Now coming to the classification. Okay, so classification, you have developmental, dysplastic and neoplastic. So what is there in developmental? In developmental kind of fibrosis lesions, you have fibrous dysplasia. In that you have monoostotic, polyostotic, craniofacial form, cherubism and familial fibrosis. Okay, so basically this is cherubism is a type of familial fibrosis dysplasia. Okay, so what you need to remember is there is developmental fibrosis lesions, and in those developmental fibrosis lesions you have monoostotic, polyostotic, craniofacial and cherubism. That is very important classification to remember right there. Then coming to the reactive, so if there is any reactive type of fibro osseous lesion, so that is reactive. In that you have periapical cementosseous dysplasia, focal cementosseous dysplasia, florid cementosseous dysplasia, familial gigantiform cementoma. Then in neoplasms we have ossifying fibroma, conventional ossifying fibroma, juvenile trabecular ossifying fibroma, juvenile semamoid ossifying fibroma. Now let us read the chapter. So fibro-ossifying fibroma, fibro-ossifying lesions. In that we're mainly discussing fibrous dysplasia. You know, we very used to saying fibroma, so I keep fumbling. Anyway, so fibrous dysplasia. So fibrous dysplasia is a developmental condition. So fibrous dysplasia is a developmental condition that is hematomatous, meaning it is benign. Okay, so fibro-osseous dysplasia is a developmental condition characterized by replacement of normal bone by an excessive proliferation of fibrous connective tissue intermixed with irregular bony trabeculae. Now the resultant bone is more elastic and structurally weaker than the original bone. The occurrence now occurs due to defects in osteoblastic differentiation and maturation. This is the etiology. Okay, not exact etiology, but it is due to defect in osteoblastic differentiation and maturation. So now the disease forms, I told you there are two types, monoostotic and polyostotic. And there are two important syndromes, that is Jaffe-Lenkinson syndrome and McCune-Albright syndrome. Albright syndrome. Now we will see what these syndromes are, and craniofacial form and cherubism. Now etiology. First is it is idiopathic, that is etiology is unknown. So the actual etiology is unknown. Then the predisposing factors or the risk factors could be viral infection, trauma, altered. So trauma is reactive to bone formation. Now what actually happens here is there is an alteration in the mesenchymal cells, and because of that mesenchymal cells here are your osteoblasts, not odontoblasts, your osteoblasts. There is an alteration in these mesenchymal cells, which is why there is a metaplastic bone formation. Now why these are becoming mesenchymal cells are altering, that cause is exactly unknown, or it could be viral or traumatic. Now mutation can also be considered as a risk factor or an etiological cause. Etiology is this NAS gene 1. So NAS gene 1 is guanide nucleotide binding protein, that is alpha stimulating activity of polypeptidase 1. So what you need to know is the full form of NAS is guanine nucleotide binding protein. Okay, so if you remember it as this, it will be easy for you, or you can just say GNAS1. You do not have to necessarily write the full form. Okay, just remember that it is GNAS1 gene, that is guanine nucleotide binding protein stimulating activity polypeptide. These are complicated full form that you do not need to remember necessarily, so just remember that NAS1 gene is causing it. Now could cause it. Coming to the pathogenesis. So pathogenesis, it starts post zygotic, that is after the formation of a zygote. Mutation occurs in the NAS gene, and that is on the chromosome, and it continues the activation of G protein. Overproduction of cyclic AMP occurs, because of which there is hyperfunction of affected organs, increased production of melanocytes, and affects differentiation of osteoblasts. So this differentiation, when it is defective, it is causing your fibrous dysplasia. Okay, so now overproduction of cyclic AMP. So what happens when there is an overproduction of cyclic AMP? So before that we need to know that what is cyclic AMP. Cyclic AMP is a vital cellular secondary messenger. So we will write here that it is a secondary messenger. So overproduction of this secondary messenger is causing your fibrous dysplasia. Okay, so what you need to remember is there is a mutation in the GNAS gene, because of which there is activation of G protein. Okay, and then this G protein is activating and overproducing cyclic AMP, because of which it is affecting the osteoblasts and melanocytes and a few organs. Okay, so first one is hyperfunction of affected organs. So there is it is affecting the organs, it is affecting pubertal organs, causing hypothyroidism, increase in growth hormone, and increased cortisol production is also occurring. Okay, so it is increased production of melanocytes. There is a syndrome that I told you about, that is your Jaffe-Lynchison syndrome and McCune's syndrome. In that you get to see these cafe au lait spots. Okay, then the severity and classification of disease depends on the early mutation that occurs in post-zygotic phase. So before 6 weeks, around 6 weeks, after 6 weeks. So before 6 weeks of intrauterine life, very early, the original cells may produce daughter cells of divergent differentiation. These daughter cells migrate to bone and endocrine primordia, causing these syndromes. Okay, so basically the mutation of the GNAS gene is occurring in the before the 6th week, which is going and mutating the original cell, daughter cell, to produce divergent differentiation. Okay, then there is these cells migrate to bone, skin, and produce several disorders and diseases. Then coming to where this is very early, this is early. Large number of daughter cells are affected that have not yet migrated to their eventual skeletal site. So there are daughter cells which are getting affected, but these daughter cells do not travel they do not travel immediately, rather they travel eventually to the skeletal site, and they migrate to several skeletal sites and cause polyostotic fibrous dysplasia. Then coming to the in 6th week, what is happening, the daughter cells will be localized to one region. If it is localized, it is craniofacial. After 6 weeks, if the daughter cells will be even more localized, polyostotic fibrous dysplasia, monoostotic fibrous dysplasia. Now we will see what this monoostotic and polyostotic is all about. Okay, so monoostotic fibrous dysplasia is a disease limited to the single bone. It is more common in 70 to 85% of all cases. So this is limited to one bone. This is limited to single bone, and it is less severe form. And the bones involved are maxilla, ribs, frenum, maxilla over mandible. So mandible is also involved, but maxilla is more involved. Then ribs, femur, tibia, craniofacial bones, and humerus. Age is 10 to 20 years. So remember, this occurs in young adults or children. Right, so it is occurring in children and young adults. Gender is equally predilected. Extraskeletal manifestations are absent. Okay, then clinical presentation is, it occurs as a painless swelling affecting the area of growth. Usually the growth is slow, and sometimes occasionally it could be rapid as well. Then oral manifestations, it is a painless swelling in the jaw. So this is in all over the body. This is specifically in the jaw. So in the jaw, the swelling is painless and usually buccal or labially occurring swelling, seldom lingual. So lingual swellings are not less commonly seen, and most commonly seen swellings are buccal and labial. Then there is tipping or displacement of teeth, malalignment, tipping or displacement of teeth due to progressive expansile nature of the lesion. Tenderness eventually develops intact mucosa. So the mucosa does not get hampered, but there is tenderness is eventually developed when it becomes a little severe. Then if mandible is involved, bulging of the inferior border occurs, and maxillary lesions adjacent to the bones are also involved. Nerves not strictly monostotic, hence not strictly monostotic. So if it is occurring in the maxillary bones and adjacent, so see, what I need to tell you here is maxilla, the lesion in the maxilla can never occur individually, because maxilla is attached to different bone at the front, like how it is attached to the zygomatic bone, temporal bone. So there are several attachments. So if it involves more than one bone, so it becomes polyostotic. But since it is in the face and in the head and neck region, we classify it as craniofacial. So it is limited to your cranium and face. So uh, this type of fibro-ossifying lesion is called as craniofacial fibrous dysplasia. Okay, then coming to polyostotic fibrous dysplasia usually involves more than two bones. So here one bone, here more than two bones. Okay, then uncommon, 15 to 30% cases of all fibrous dysplasias. So this is more common, this is less common. Severity ranges from a group of few bones to most bones in the skeletal system. Then what are the bones affected? Femur, tibia, pelvis, ribs. So the bones which are affected are femur, tibia, pelvis, ribs, skull, facial bones, upper extremities, lumbar spine, clavicle, and cervical spine. So all these bones are affected, and early symptoms appear before 10 years of age. Okay, so here also the age predilection is in young children, okay, less than 10 years of age. And coming to the bones, it is femur, tibia, pelvis, ribs, skull. So majorly occurring in long bones. Then coming to your smaller bones, right? Then it is having an extraskeletal manifestation. Unlike the monostotic, it is present in other bones as well. So in this we're going to study two syndromes, as I told you earlier. First is the Jaffe-Lynch syndrome and McCune's syndrome. So what is Jaffe-Lynch syndrome? So that is that polyostotic fibrous dysplasia is occurring with cafe au lait. So cafe au lait is coffee with milk like pigmentations on the body. Okay, so coffee with milk like pigmentations on the body is cafe au lait. And McCune's Albright syndrome is polyostotic fibrous dysplasia with cafe au lait spots, that is coffee with milk spots, plus multiple endocrinopathies. So here something new is endocrinopathies. Okay, sexual precocity, pituitary adenoma, and hypothyroidism. Okay, so these are endocrinopathies. Then there is something called Maza-Brand syndrome, rare polyostotic fibrous dysplasia plus intramuscular myxoma. So here something called as intramuscular myxoma is occurring. This clinical presentation is this: the bone pain and spontaneous fractures are initial findings. So there is bone pain and spontaneous fractures, which are the initial findings. Then there is the disease affects unilaterally. Okay, so it affects both the sides. Bone pain and spontaneous fractures are initially occurring in this type of dysplasia. Okay, and long bones are bowing, and leg length is discrepancies is seen in the length of the leg as a result of involvement of the upper portion of the femur. This leads to a deformity known as Shepherd's crook deformity or hockey stick deformity. Okay, then coming to monostotic and polyostotic, again we have in monostotic we discussed something about craniofacial fibrous dysplasia that was restricted to the face and cranium. This disease is limited to craniofacial bones, frontal sphenoid. See, I told you the bones associated with the maxilla, sphenoid, frontal bones, and your zygomatic, all the bones involved with the maxilla. This is a painless enlargement resulting in disfigurement of the face. So there is a disfigurement of the face. Maxillary lesions extend locally to involve maxillary sinus. So if there is a painless enlargement, the face is disfigured, the symmetry of the face is lost. Then coming to the maxillary lesions, they extend locally to involve maxillary sinus, zygomatic process, floor of the orbit, and even extend backwards towards the base of the skull. So if the infection is involving if the fibrous dysplasia is involving the maxillary sinus, so it will involve the zygomatic process, the maxillary sinus, floor of the mouth, and even extend backwards towards the base of the skull. Then there is severe malocclusion, expansion of canine fossa, extreme prominence of zygomatic process produce facial deformity. Okay, so if there is severe malocclusion, there will be facial deformity, as we discussed earlier as well, an expansion of canine fossa and extreme prominence of zygomatic process. Then polyostotic fibrous dysplasia has cutaneous pigmentations. Cafe au lait we discussed. Now we have to elaborate the cafe au lait. It is well defined. Okay, let's just say if it is a round kind of a macule, then it is well defined. It has borders and it is unilateral. That means it occurs only on one side of the body. Tan macules occur on the trunk and thighs, so it can occur on the trunk and thighs. Pigmented oral mucosal macules also may be present. So oral macules is one important feature here. Okay, then it may be congenital, irregular margins. So there are these irregular borders, so the borders are well defined but they are irregular. So these irregular borders resemble the coast of Maine. Okay, so the coast of Marine, I guess this is Marine, not Maine. Let me check. So the coastline of, let me check, guys. Yes, I have looked through it. So it is coastline of Maine, not Marine. Okay, Maine, coastline of Maine. Okay, Maine, coastline of Maine. Okay, then the DD is differential diagnosis, could be neurofibromatosis, and then so neurofibromatosis has cafe au lait spots as well. So cafe au lait spots borders are smooth, bilateral, and they also look like coast of California. So if you can write coast of Maine or coastline of California. Coming to the endocrinal disturbances seen in your Jaffe, what was that? Yes, in the McCune syndrome, that endocrine disturbances are precocious puberty, hyperthyroidism, adrenaline disorders, diabetes, and hyperpituitarism. Now, oral manifestations are similar to monostotic ones. So what were the monostotic oral manifestations here, like facial deformities and everything? Same, plus jaw, loss of bone support, and endocrinal disturbances are majorly occurring here. There is a delay in eruption, altered eruption sequence, dislocation, and malpositioning of the teeth. Coming to the radiographic features, so yes, we are towards the end of it. So radiographic features, the radiographic features include monostotic, there are three patterns of monostotic. There is cystic and ground glass. So if it is cystic, so monostotic, what are the three patterns is I will tell you, but before that there is something called as cystic. If it is cystic, then it is unilocular or multilocular, well circumscribed border, rind sign is seen with thick sclerotic border. Then you see ground glass appearance in this fibrous dysplasia, which is like an orange peel appearance. It is seen in the mature lesion. In the radiograph, it is usually radio-opaque spicules in the radiolucencies. Then peripheral radiolucencies is ill-defined and appears to be blending with the surrounding normal bone. So the three variants are translucent, opaque and mixed. Then coming to the sclerotic is basically opaque and it has increased trabeculations. And if it is sclerotic, there is cortical plate perforation. So in the monostotic, we don't see any cortical plate perforation as such, and no roots are separated. Occasionally severe resorption could occur, but there is no cortical plate thinning. Then in mandible, there is expansion of cortical plates, superior displacement to the inferior alveolar canal, and in periodontal space is a ill-defined lamina dura blends with abnormal bone pattern. So this is basically how it occurs in the mandible. Then in the maxilla, when maxilla is involved, the lesional tissue displaces the sinus floor, commonly obliterates the maxillary sinus. This is the craniofacial. It obliterates the maxillary sinus and increase the density of the base of the skull. Okay, so it increases the density of the base of the skull, and it is a characteristic feature of fibrous dysplasia of skull that it is intensity is increased the density of the base of the skull. Okay, then what are bones are involved? The occiput, sphenoid, roof of the orbit and frontal bones. Then coming to polyostotic, so we discussed monostotic, craniofacial fibrous dysplasia, and now polyostotic, the medullary portions is calcified, irregular trabeculations is seen giving a multilocular appearance, cortical bone is thinned and expanded. But do we see perforations here? Maybe. Okay, then coming to the histopathology, the histopath is it has bony trabeculae. So you will see all the bony trabeculae in the histopath, and the shape of the trabeculae is of an immature woven bone. We remember we had drawn the Haversian canal and the woven bone, which is not connected to each other. It is C-shaped, and Chinese letter patterns can also be seen. Right, Chinese letter patterns can be seen. Arises by metaplasia, not surrounded by oppositional osteoblasts. Typically, osteoblastic rimming of the bony trabeculae is absent. That is not important. So basically, we see osteoblastic rimming on the end of the bone. So it is oppositional. Bony trabeculae is absent. So there is absence of bony trabeculae, and it is low to moderate cellular fibrous connective tissue. Okay, so basically the histopathology is it has woven bone, that is your immature bone. It has Chinese letter pattern. So the histopathologic features of polyostotic and monostotic together are they majorly have immature bone, woven bone, and the woven bones are not connected to each other, and they have a Chinese letter pattern. They arise by metaplasia, not surrounded by oppositional osteoblasts. Typically, osteoblast rimming is seen. Bony trabeculae is absent. This is very important. At the periphery, the lesion blends with the normal bone. The lesion in the jaw may undergo progressive maturation. So the lesion in the jaw undergoes maturative progression and consists of lamellar bone and moderately cellular connective tissue. The bone trabeculae run parallel to one another. Low to moderate cellular fibrous connective tissue is seen. So it's slowly getting replaced, so that's why you're seeing low to moderate. Multiple delicate capillaries are seen throughout the lesion. If injured, it may incite a giant cell and cell reactive process. The DD could be non-ossifying fibroma, aneurysmal bone cyst, fractured callus, giant cell tumor, low-grade osteosarcoma, jaw bones, ossifying fibroma. The treatment is non-specific, so the treatment is, since the disease is self-limiting, there is no specific treatment. Small lesions could be, no surgical intervention is required because it is not damaging anything as such. So monostotic fibrous dysplasia, cosmic surgery if there is an expansion, and diffuse lesions, surgical resection, big if they are big. The patient in whom the surgery is contraindicated is okay. So vitamin D and bisphosphonate therapy is given for the treatment, and in few patients who have big lesions in them, the surgery would be contraindicated as well. Radiation, basically we're talking about the radiation is also radiation is contraindicated in this therapy. If there is a radiation for any of these, it could lead to osteosarcoma, fibrosarcoma or chondrosarcoma. Recurrence is 25 to 50%. Okay, then there is McCune-Albright syndrome in detail, and then there is, yes, this much is there for fibrous dysplasia. Okay, well, I know this video wasn't great because it is not very in detail, so even then, if you understood something, please subscribe to my channel. Thank you for watching.